ទី7ខេត្តសៀមរាបដឹកនាំជាមួយលោកសាស្ត្រាចារ្យ Vincenzo Canizaro ជាសហប្រធានអាសនៈលោកជាប្រធានផ្នែកជំងឺធ្ងន់កុមារនៅមន្ទីរពេទ្យកុមារ Zurich លោកសាស្ត្រាចារ្យទាំងពីររូបនឹងដឹកនាំ Plenary Section 3ដែលមាន3ប្រធានបទនិងមានរយៈពេល60នាទីសូមគោរពអញ្ជើញ
We would like to hand over to Professor Kantha as a chairman. He is the director of J. Vadaman 7 Children's Hospital in Siem Reap, and Professor Vincenzo Canizaro as a co-chairman. He is the director of PICU unit in University Children's Hospital in Zurich. Both of them lead plenary session 3, which consists of 3 topics and lasts for 60 minutes. Thank you. Please come.
So welcome back to everyone. We go on with the third session. I would like to introduce Professor Jean-Claude Faucher. He works at the University Hospital Zurich, Department of Neonatology, and he's professor in neonatology, a lot of expertise in many fields of neonatology and intensive care, but with a special interest in nutrition. So the topic he will talk about is about parenteral nutrition in the NICU.
Thank you, Vincenzo. Thank you, Professor Kantha. Dear colleagues, dear participants. We decided to separate the topic of parenteral nutrition in 2 topics, so it will be a duo between me and Professor Canizaro, because on the neonatal side we didn't start parenteral nutrition yet, so we are on the verge to start, whereas in PICU it's sort of daily use. So what's the background to start parenteral nutrition in neonatal intensive care? So if you look at the development in the Kantha Bopha hospitals in Phnom Penh, but also here, there were several developments over the last couple of years which led to a significant increase in survival of infants who had not survived before. Mechanical ventilation, non-invasive respiratory support such as CPAP, among other interventions, helped to achieve this increase in survival. Moreover, in terms of surgical treatment for infants with congenital anomalies, there is a huge progress here in these hospitals. So on one side we have an increase in survival, and on the other side we find it not sufficient just to have more babies leaving the hospital. We are now in the situation to address the long-term outcome of these babies. And if we speak about long-term outcomes, especially in preterm infants, but also in infants who otherwise would not be ideally fed, that would be a big problem, and it would be also an ethical dilemma. So just looking at what happens sort of in the last part of gestation, if we look at this cartoon by Joseph Volpe, so we have here an infant, a fetus, with a brain weight of roughly 130 grams at roughly 28 weeks. And if we look at the brain weight at term, that's a 3-fold increase in weight. So to achieve this increase in brain mass by cellular division, by connectivities, etc., we need to address the topic of a high-quality nutrition of these infants. Otherwise, you don't achieve this goal. Moreover, if we look at what happens in late gestation, we know that around 32-34 weeks, there is a huge increase in transplacental passage of nutrients, of immunoglobulins and other substances, which altogether allow for trimester spurt in growth. And if we then take the babies born before that cutoff, 32-34 weeks, we have sort of a deficient situation. So we need to address this situation by having an optimal nutrition. So the aims to improve both enteral and parenteral nutrition is to sort of to approximate the intrauterine nutrition. So we are in exonutrition situation, but we would like to have sort of the same growth while the baby is already born. And with that, we mainly want to prevent brain damages, and by that ultimately improve the long-term outcome of these babies in terms of neurodevelopment. So what is the profile of babies needing parental nutrition? And I like this sort of a short sentence by Dudrick and Rudbeck, who said, basically, these are kids who cannot eat, should not eat, or cannot eat enough. And this is not relevant to neonatal medicine, but in older infants and children, you have sometimes babies who will not eat enough. Anorexia would be such a situation. So looking at the neonatal situation, we're looking at preterm infants born before 32 weeks gestational age. We have good evidence showing that if you provide parental nutrition to preterm infants over 32 weeks, there's not a big or a significant change in long-term outcomes. So you spend money basically without any significant improvement. Then we have the group of the very low birth weight infants with a weight at birth below 1,500 grams, and then these infants with mainly gastrointestinal anomalies, infants under asphyxia, or with or without therapeutical hypothermia, infants with hemothorax, infants with significant weight loss, nutrition deficit, or a failure to grow. This is just a slide. This was the first group in 67 in the States. This was a baby born at term, more or less at term, 2.3 kilograms at birth, who had small bowel atresia, partial colon atresia, and post-surgery had a significant problem with growing. So this was the first published infant who was put on parental nutrition by Wilmore and Dudrick. So what types of parental nutrition do we know or do we use in neonatal medicine? We have the total parental nutrition, meaning that the full nutrition is provided through parental approach. Then the more frequent case, and that's important and a good message for us, quite often or most of the time we can embark into partial parental nutrition, meaning that a part of the nutrition is given parentally and the rest is given enterally. We have, when we do that, most often it's sort of a starter parental nutrition containing sugar, dextrose, and amino acids and electrolytes, whereas the full parental nutrition would have all the nutrients you would need, meaning fat, amino acids, carbohydrates, micro and macronutrients, etc., trace elements. And this is also important to us. We have two ways to give it. One is peripherally, and we would always try to do that. We have sort of a limit. It's not a very good situation in terms of strength of data, but we are looking around 900 milliosmol. That's sort of the cutoff to decide between central and peripheral approach. I like this slide. We have here on the y-axis the age, and on the x-axis we have the calories per kilogram body weight. And as you see here, for the infants or below 1 year, we are looking at roughly 120 kilocalories per kilogram per day, whereas most of us would be sort of around here. It's about half of this amount of calories per day, and you see the different sort of compositions or the basal sort of need, which is around 40 to 60 kilocalories per kilogram. And then we have another sort of important topic, that's growth. We need 3 to 4.5 kilogram per weight gain, per gram weight gain per day. So if you look at the weight gain in preterm infants of roughly 15 to 20 grams per kilogram per day, you would need an additional 45 to 67 kilocalories per kilogram per day. If you add that together, you're sort of around 120 kilocalories per kilo per day. And then there are sort of special topics. Exercise is rarely sort of done in preterm infants, but by exercise we mean activity. If you look at babies with a bronchopulmonary dysplasia, with a huge work of breathing, then that's exercise basically, and that adds to the need in terms of kilocalories. I won't dwell too long on this, but we have to know when we sort of set up the parental nutrition on the daily visit, we need to know sort of a few basics, concepts in terms of, I just spoke about that, the energy, which is between 90, 110, 120 kilogram per day. If you look at the non-protein part, that's 25 to 40% in fat, and the remaining in carbohydrates. This is a very important aspect, the fluids, and the more immature the baby is, the more fluid you will need to address the insensible losses of this baby, and the fact that these babies, they are sort of roughly 90-95% of their body weight is water, with an increased extracellular volume, and by that the danger to lose water. So we need to address that, and one way is to look at the weight sort of development over the days, and to look at, for instance, sodium in the blood. Protein, we are sort of aiming at 3 to 4 grams per kilogram per day. Carbohydrates, 4 to 15. Values can change a little bit depending on the reference you're using. I will show you some data afterwards. Fat, micronutrients. What is important is that you can't take sort of a pen solution for all the children or adults and just adapt that without any sort of changes to a preterm infant. So what we're looking at is to have proper parental nutrition bottles or bags which are for preterm and perhaps for the younger term infants. That's what we are looking at the moment with the PQ and Professor Becker. I won't sort of go into the details here, but this is just to show you that you have very good references when you're looking at what types of need, and in terms of term or preterm infant, in terms of age, postnatal age, what are the needs in terms of fluid, of energy, and these data come from 3 important international societies or institutes, and I think it's very helpful in daily practice. The same for carbohydrates, protein, and fat. And I put you in the PDF. You have also all the tables for the trace elements, vitamins, etc. So in terms, I already sort of touched on that, the peripheral vein delivery, I would always try to do that, and that's easier done if you have sort of a partial parental nutrition, and then going into central vein delivery, we have the possibility after birth to place an umbilical venous catheter. The problem, it's very easy to place, but we don't like umbilical venous catheter staying for more than 3 to 5 days, because that's sort of an infection route, which you see less often in umbilical arterial catheters, but again, then you need to be able to place them and to have a proper location of the catheter. The other way is to place sort of a peripherally inserted central catheter, a so-called PIC. That's feasible. But again, there are a couple of things to consider when we embark in this technique. It's also important to know the material used. There is stiffer or less stiffer material. The stiffer ones are easier to insert, but they have some problems. I will show you afterwards one of the problems. Yes, you need the skills to do that. You need to check for the catheter position, either by X-ray, or we do it quite often by echo. And this is perhaps one of the most problems at the moment. We would like to be able to place these central catheters, but we don't want to have an increase in catheter-associated infections, where then you lose babies. What is important? It's so important to start enteral nutrition right on the first day, and it doesn't matter if the baby is in respiratory distress. So feed your babies right from the birth. You have a gastric zone, you can feed the babies, so we don't lose time, and then we can add some parenteral nutrition on top of that. You all know that maternal, I'm not sure if you have that here, donor human milk, but also from a certain point of age, then to start to fortify this milk. We have special preterm enriched infant formula, and this is also an important aspect once you are on parenteral nutrition every day, to consider, do we continue to need this parenteral nutrition, or can we retreat from it? So the shorter you use this technique, the less problems you will have. I already told you about the weight increase. That's important to monitor that every day, so that you're sure that you are on track with the weight gain. We do that regularly by putting the infant's growth parameter, sort of the length, the weight, and the head circumference, on charts. These charts have to be adapted to the population studied. If the baby doesn't sort of stay in the centiles, then you have to consider adapting your nutrition, and you need also to check the possible metabolic consequences of having a parenteral nutrition, and these are sort of the exams you do regularly, or for other ones less regularly. That's mainly on infants. Perhaps Professor Garnizzaro will touch on that, who are on a longer time on parenteral nutrition. That's the scheme we use in Zurich in our unit. I just explain what we have. These are the babies with a birth weight between 1,250 and 2,000 grams. This is the time after birth in days. That's a total fluid, an increase of 20 per day, as long as the baby is okay with the sodium, etc. And then the next step is to decide on what is the enteral amount you are going to give these babies through the gastric zone. We increase by 20 mils per kilogram per day. Don't be afraid of necrotizing enterocolitis. That's rarely associated. If you increase by 20 mils per kilogram per day, you will rarely have a neck due to that. So if the baby has a neck, there are other reasons for that. And the rest will be as parenteral nutrition. For the babies within that weight range at birth, we use a 10% parenteral nutrition, and we stop that once we reach sort of 120, 130 mils per kilogram per day. And for the other ones, over 1,500 grams, we use glucose 10 the first day, and then a mix between glucose and sodium. And then you add on that your vitamins. So what are potential problems? One is, as I already said, inadequate parenteral nutrition preparations for the given group you have on your unit. Then sort of metabolic problems, hyperglycemia, metabolic acidosis through the proteins, hypertriglyceridemia, fat, and if longer time, classically infants with a congenital chylothorax could have this problem. Quite often we also have problems in terms of compatibility with other medications, so you need to check what you're mixing at the same time or infusing through the same line, precipitates, and I will just show you showing you a picture, some complications we can have. This is a classic one, sort of an extravasation with a necrosis. This is an infant we had very recently, where we had on one side the central line here coming via the superior vena cava, and for some reason we had to place a second one, which was easy to insert. It was here, sort of in the right atrium, stayed there for very few hours, and what happened is This was a stiffer catheter, a Primicat, and we had a perforation into the pericardial sac. This is another problem you can have, especially if you are sort of on long-term parenteral nutrition, a rupture of your PICC line. So this one is easy to take out, but this one had then to be extracted by surgical means. And you see the sort of the discolor here of this leg in comparison to the other one. So I come slowly to the end. One of the central sort of topic worries we have is the catheter-associated bloodstream infection. That needs sort of a very strict adherence to international protocol, which should then flow into the local protocol, so that we don't have that problem too often. To set up a full parenteral nutrition is technically difficult and is expensive. We have problem with some contaminants, aluminium, chromium, magnesium, solution compatibility, mainly calcium and phosphate, depending on the concentration, on temperature, on osmolality, and other sort of mixed product. And what we see now increasingly, that's a worry to us, shortage of product. As a sudden, we don't have any parenteral nutrition. And we live in Zurich, in Switzerland, so you see that even in richer countries, we also face a problem of shortage. This was given by my boss in Australia on my way to become a neonatologist. So the thing here, that's an Australian seashore, and the thing is, it's only safe between these two flags. And many things we do in neonatal medicine is dangerous, so we have to stay within sort of less dangerous areas. And I finish with that, just to give you some thoughts, what we have to deal with when we embark on this technique. Yes, on one side it's essential to have parenteral nutrition for the type of babies I alluded to. We have to have a strict indication. So if we have a problem, but we can say the indication was a very good one, a strong one, so okay, so we deal with the complication. We have to put a huge weight on an optimal enteral nutrition at the same time as we have the parenteral nutrition, ideally. There are some infants who cannot be fed enterally, that's another problem. So one sort of sentence you should take with is, if the gut works, use it, and use it right from the birth. We have to optimize our enteral nutrition. We stop as soon as the full enteral nutrition is achieved. A strict adherence to hygiene protocol. We will have to set up these SOPs when we start with that technique. We have to monitor for metabolic complications and also for growth and development. And I finish with that. So that's the baby at the beginning, and you see the weight increase. That's impressive. Thank you very much.
Thank you very much, Professor Jean-Claude Faucher, for this parenteral nutrition.
I would like to invite Professor Vincenzo Cancizano to have a presentation. Thank you.
So thank you very much for the invitation. I'm also honored to be here. I will continue talking on the same topic as Professor Faucher did, but with a focus on pediatric intensive care. So we wait for the slides to start. I know it works because we tested it. So, yes. So what are the main topics? The main topics to discuss are, first of all, the rationale. So this is why are we doing it, the content, what are we using, the application, so the technique, the timing, duration, assessment, and challenges. So the rationale. If we think about enteral or parenteral nutrition, we very often think about underfeeding. And if we think about underfeeding, then these are some of the problems we might encounter. Impaired growth, loss of body tissue, including lean mass. What does it mean? Lean mass is the mass without fat. Otherwise, someone would think it's always good to lose a little bit of fat, but this is the lean mass, so we don't want to lose the lean mass. Impaired development, impaired immunity, and respiratory failure. I will pick this again up, because there is also an issue with overfeeding. So it's easy to say we are applying high energy, high nutrition, high calories, and to think that this is a good thing. But be careful, because overfeeding is associated with hyperglycemia, infection, impaired liver function, steatosis, which can be a very challenging disease, abnormal metabolic programming, and again, respiratory failure. So now you might think, maybe this is a mistake I made, because I have respiratory failure here and respiratory failure here. So let me say that mechanical ventilation is still the most important thing in intensive care. So it turns all around mechanical ventilation. And we will get there why respiratory failure is associated with under and overfeeding. In the end, if you look at these complications, and this is the main problem we are facing, all this results in increased morbidity and mortality. And if we want to be very tough or severe with us, then we have to say, at the end of the day, if you work in intensive care unit, this is all about quality and outcome. So if you produce this morbidity because you're under and overfeeding, then it's relevant. So looking back, one step back, a little bit of physiology and biochemistry. Generally, we are talking about carbohydrates, lipids, and proteins. Professor Faucher gave some numbers. I will not focus on that. The body nature is smart. So what does the body do? We have macronutrients. They will be catabolized to micronutrients, and if possible, if the body has the best conditions, from micronutrients there will be an anabolism to macronutrients again. If we think in terms of partitioning, where and what for do we use this food, this energy, then we have to satisfy the basal metabolic rate, also sometimes termed as the resting energy expenditure. So that is me at home watching TV and not doing anything else. So this is the basal rate. Then there is diet-induced thermogenesis. This is still me eating, chips and drinking a cola. So this is also something that needs to be metabolized. And then physical activity. This is maybe someone practicing sport while watching TV. And then in infants and children, we are talking about growth. So it's important to understand that there are important parts and they are different between patients. And now it's not about me watching TV, but it's about sick patients. So in a critically ill patient, we have to understand that there's a big difference if a patient becomes sick and has a history of malnutrition, or if he comes in the ICU and he is normally in terms of growing. There's also a big difference if we think about a child with burn injuries, because with burn injuries you have a completely different metabolic demand, which can be up to 5 times higher. So a patient with burns will have a completely different demand. In traumatic brain injury, it's at the beginning the opposite. In traumatic brain injury, we will do everything in the first 24, 48 hours to keep the patient quiet, a high sedation. We don't want him to be stressed, so his metabolic demand again is different. So when it comes to the question, okay, we acknowledge that there are differences, then how do I know in my daily business practice which patient needs what? In theory, I can base it on my experience. This is always bad because we are not perfect and risk of human error. Charts, yes, we can use charts. We can see where the patient is currently. We can compare with other patients, other children. You can do some lab analysis. You can use equations, and you can also use the indirect colorimetry. So I will focus on these two. You will find many equations. This is just an example. Don't be concerned if you can't read it up there. There is the reference in the PDF then. But important is the fact that we do have this Schofield equation to calculate the REE, resting energy expenditure, and we make a distinction based on age, boys and girls, and then we can calculate some data. If we look further, so the development, this is a table 2 of this paper from the European Society of Gastroenterology and Hepatology, where my esteemed colleague Professor Christian Brecker is member of. And this is the table showing the requirements for parenteral nutrition in different phases of disease. And this has been a big improvement, understanding that an ICU patient at the beginning of the disease is different compared to an ICU patient in a recovery phase. So at the beginning, if you look at the right side, this is the acute phase, you will have less when compared to a stable phase and when compared to a recovery phase. So it's important to understand it's not only about the disease, but it's also about the phase of each disease, which makes it quite complicated. What is indirect calorimetry? Indirect calorimetry assesses the oxygen consumption and the carbon dioxide production. You may have read or heard about this term respiratory quotient, so RQ, which is calculated based on this carbon dioxide production over oxygen consumption. And what does it mean? So it sounds maybe a little bit complicated, but to break it down and make it more basic for everyone. So food in general can be considered as a fuel for energy. And why do we have to eat? Because we need energy. And to make it very maybe oversimplified, but I like this idea or this concept, you eat, so there is food, you have macronutrients, you need oxygen for this process, and in the end it results in CO2, in water and heat. And heat is in Latin calor, so this is why it's calorimetry. And indirect calorimetry, normally you would measure direct heat, but this is too complicated for intensive care setting. So this is why in practice we use this indirect calorimetry. So you have an intubated patient with a tube, you insert a piece which can measure the gas, and then you can do some calculations. And here you see on the right side that it makes a difference if you look at carbohydrates, fat or protein. Carbohydrates, they have an RQ of 1. How do we get this number 1? So it's quite easy. You have 6 units of oxygen, which will provide 6 units of CO2. So 1 divided by 1 makes an RQ of 1. But this is only true for carbohydrates. If you look at fats and if you look at proteins, you will generate different values. And now to the question, respiratory failure. So respiratory failure in a child that is underfed can be explained easily. If you don't have a muscle mass, then you won't be able to use your diaphragm, you won't have the power to breathe. You don't have the power to cough, so you need muscle power to be able to get rid of your tube. So this is easy. But overfeeding is a problem because, as you can deduce here, if we use a lot of fats and a lot of proteins, you have something below 1. Something below 1 where this ratio means this value here is smaller than this value here. So this will generate a number below 1. Is this important? Yes, because if you're overfeeding, you will have patients with a higher metabolic demand because you overfeed them. They have more CO2 that is being produced, and somehow you have to get rid of this CO2. meaning you have to ventilate more and longer. So this is why respiratory failure is a problem in both conditions. So now the more easy part, there are guidelines, as you can see. I'm not going through these guidelines. I'm just trying to tell you that there are guidelines, and these guidelines have been published. You can see in different papers, in different journals, and here this is intentionally that you can't read it because we won't talk about it, but this is the answer to when to start, how to apply, frequency, what kind of solution to use. 2 tables, and for me, then the question comes up. Okay, so Professor Faucher told us how it works in preterms and in terms. I was trying to explain how it works in children. We have the data, we have the guidelines, so what are we waiting for? We could start today or tomorrow, but it's not that easy, because before you do that, you have to teach and have very broad knowledge. Broad knowledge means that every person working in the ICU needs some basic understanding, otherwise it's too risky. You have to decide which solutions and products to use. You have to think about storage. It's not that easy. It's not over if you buy it. You have to think about where to store it, room temperature, expiration date. Then the application issue. You have to have a concept. Will you work with the groin central line, subclavia, jugularis? Who is putting the lines in? How do you check the right position? What is the rate of thrombosis, of central line associated infections? Then you have to develop a checkup program, because you have to be sure that it works. Clinical assessments, laboratory assessments. What is the frequency? What do you want to measure in what time? It's also very cost intensive, so you need to think about that before. And then something that is surprising to me all the time, the implementation. So you might think in Europe or the United States, we have all these concepts and it works very well. It's not true. If you measure at the end of the day how many patients were fed as required, you will be disappointed. Because even there it doesn't work. You have a lot of patients not receiving what they need, too much or not enough. And so you need also a concept which has to be developed professionally, interdisciplinary, before you start. So summary and take-home message from my side, nutrition is key. Nutrition is important in terms of quality and outcome. It is challenging in the PICU setting, because the PICU setting is very special with this heterogeneity of patients you will care for, from the neonate up to the 18-year-old with all these different pathologies. So this is really challenging, but it's doable. Assessment part of ICU routine. So now we are used to ask for saturation, blood pressure, respiratory rate, but we are not so good in asking what is the nutritional status. And this has to change. This has to become part of daily routine. Then enteral whenever possible. So if we have to, parenteral. But if we have a choice, enteral will always be better. So if this is a football game, enteral will always win over parenteral. So we have to use that option. And then, as I said, the implementation, quality control, critical incident reporting, this is absolutely key, because it starts from the logistics, pharmacy, gastroenterology, intensive care, infectious disease specialists, and everyone has to be involved. So this is a very good example where I believe that you need this, okay? You need, well, it doesn't matter, you need this preparation with a concept as a prerequisite to be able to start. Thank you very much.